we're going to switch gears now to talk about germline classification. And first, I just want to thank the organizers for this opportunity to speak about a topic that has fascinated me since I started working in clinical genetics, now over 10 years ago, and that is the use of variant effect predictors in clinical variant classification. And this is a talk that piggybacks off of the talk that Stephen Brenner gave last night, which so beautifully sort of laid out the state of the art of how we use these models in variant classification. And I hope to introduce to you now a new method that we think will even push that a bit further. So to just make sure we're all on the same page, I'm just going to quickly review what we actually do when we clinically classify variants. And ideally, what we do is we have a patient that has a particular presentation, and we can find established pathogenic variants that explain this presentation, and in the ideal case, there's even medical interventions that we can offer to these patients to help potentially reduce risk of certain manifestations. But what happens even more often is we find variants that just either haven't been seen before or are super rare, and we don't immediately know what to do with these findings. So when we are presented with a new variant, what we do is this process called clinical variant classification, and we try to bin these variants into one of 5 bins from benign down to pathogenic disease-causing. And what we do is we collect data from all possible sources of evidence, and then from that collection of evidence, make an interpretation. So if we look into ClinVar to see how we do with rare missense variants, what we can see is that for most newly identified variants, these get interpreted as uncertain significance. So this is that VUS problem that has been mentioned in some of the talks yesterday. So variants of uncertain significance are this black line, and they're increasing rapidly over time relative to known pathogenic and benign interpretations. And the reason for that is typically quite simple. It's just these variants are extremely rare, and we just don't have most of these sources of evidence that we typically use in interpretation. One piece of evidence that we always have are these variant effect predictors, because these can make predictions for all possible missense variants. But it's not all bad news. So we and others have shown that if we have multiplex functional data and we integrate that into these clinical classifications, we can actually move the needle for this VUS problem. And so this is a figure from a recent review that we put together led by Abby McEwen that shows that for some of the MAVEs that have been published and integrated into clinical variant classification, we can reduce about 55% of VUS from clinical testing. And so that's just a real testament to the strength of this community, and when we focus our efforts on some of these clinically relevant genes, how many variants we can actually reclassify. And in fact, now we have data for around 1% of all of the clinically relevant genes. And so this is actually a huge number, and this is a figure that Malvika put together that shows the number of clinical tests for a gene by the number of possible SNVs in that gene. And the genes are colored by whether or not we have functional data. And so the darker purple ones represent the genes where we have functional data. And the size of the dot is relative to the number of VUS. And so this 1% figure has really inspired what I think is a very ambitious project to really scale up this variant interpretation effort. And so what we're aiming to do now is use nearly 300,000 variant effects measurements across 41 disease genes and apply that to variant classification. So what this looks like is first a massive curation effort for previously published data. A lot of these data sets were published by folks who are sitting in this room, as well as 60,000 newly generated variant effects measurements by both the Fowler and Starita Lab production scale efforts. And then all told, what this represents is about 30,000 variants that are mapped to NOMAD, roughly 25,000 variants of uncertain significance, and 21,000 control variants. So what we aim to do is show how many variants of uncertain significance we can reclassify by combining the multiplex data as well as the variant effect predictors. And I should also mention we are collaborating with clinical labs who are sharing their data with us, but something we know from our previous experience working in this space is for most of these clinical VUS, these are really the only 2 pieces of evidence that we'll have. And so to learn a little bit more about the data that has gone into this project, I encourage you to check out some of the posters from our groups. So Sylvia, Ivan, and Katie will be presenting posters, and Katie has a talk tomorrow about some of the data generation. Ile has a poster related to the topic of this talk, which is calibration of variant effect predictors. And then Malvika has a poster that looks at sort of all of this all together, where we're at today, and where we plan to go with this project. And the success of a massive scale project like this really depends on how we calibrate the data. And so we have made gains on the calibration for both the functional data as well as the variant effect predictors. To see some of the work done on calibrating functional data, I encourage you to check out this preprint from Dan Zeeberg, where he's updated our use of the functional data in clinical classification. But the main topic of this talk is sort of our efforts to improve the calibration of variant effect predictors. So when we do this calibration for clinical classification, essentially what we're doing is we're determining how we are going to use a piece of evidence in variant classification. So for this talk, I'm going to focus on the variant effect predictor REVEL. And so REVEL is going to score variants from 0 to 1, 0 being more predicted to be tolerated by a protein, and 1 being more predicted to be deleterious to a protein. But if we have this, this score range, what we have to do in clinic is sort of set down thresholds and establish where we can apply benign evidence and pathogenic evidence. And so the way that we do this, and I won't go into great detail because Stephen really did a great job of explaining this process, but we have to take some known control variants. So this is a representation of all the known pathogenic and benign variants in ClinVar that are measured by REVEL that weren't used in training the model. And so what you can see is that the model does a great job of separating known pathogenic and known benign. And then, as Stephen described, we can actually now calibrate this model with the entirety of ClinVar and what we're calling this genome-wide calibration, and set down thresholds for benign evidence. So anything in this blue range will receive benign evidence with increasing strength as you approach a score of 0. And then pathogenic evidence on the right side with increasing strength now as you approach a score of 1. And then there's indeterminate evidence where you get no evidence in the middle, where the model is neither predictive of pathogenic or benign. But this was a huge leap forward for how we use these models in clinical classification, which before were sort of loosely set at supporting evidence as a cap, but now we can achieve strong evidence. The one thing to note, though, with this mode of calibration is that it makes this assumption that all genes will have a similar distribution of scores. And what we have found, taking sort of a deep dive into how this genome-wide calibration performs at the individual gene level, is that many genes actually violate that assumption. So here's a gene, TSC2, where you can sort of immediately appreciate that REVEL does a good job of separating pathogenic and benign variants. However, if we look at the genome-wide calibration thresholds, what we see is that most of these benign variants fall into the indeterminate range, where that calibration says there's no evidence. And so these thresholds are probably inappropriate for this gene TSC2. And one thing that we also noticed when we did this deep dive is that when you look at the scores for all possible predictions of a gene, they actually mirror sort of this distribution, where we have this right shift of all predictions. And so we could potentially use that to our favor in calibrating these models. There's also genes that have sort of the opposite shift, so left-shifted distributions where the model is still doing a good job of separating pathogenic and benign, but again, the genome-wide thresholds might not be appropriate for this gene, USH2A. And so I've used these two examples because they have a lot of clinical control variants, so we can sort of appreciate these patterns. But in these cases, because we have so many control variants, we can actually solve this problem by calibrating these genes individually. And so that's what Ilei's poster focuses on, is for the cases where you have enough control variants within an individual gene, how we can sort of use those variants to calibrate genes individually. But the rest of my talk is going to focus on the cases where we don't have enough control variants for individual gene calibration. And The one thing I want to touch on before sort of jumping in to how we do the calibration is that the changes in distributions that we notice are actually driven by the protein domain level, not the individual gene level. So this is a gene, COL1A1, type 1 collagen, has these 3 functional domains that all have very different Revel score distributions. Each one of these functional domains has known disease-relevant variants, and they're all distributed differently because we have a wide diversity in the Revel score distributions. And so, I just told you that, very few genes actually have enough control variants to be calibrated individually. And now I'm saying we should break this down to the individual domains, which actually means even fewer domains now have enough control variants. And so it's actually about 1% of all domains that have data in Revel actually have enough variants to be calibrated. So the solution to this problem is we can take advantage of what we learned about these distributions to actually group domains by their distribution shape. Because when we see a particular distribution shape, we can almost predict where the pathogenic and benign variants will land. So what this looks like for this gene COL1A1, we can look at sort of these functional domains. And the first one is a collagen domain. And there are many collagen domains across many different collagen genes, all of which have a very similar predictor score distribution. These other functional domains as well have similar sort of right-shifted distribution. In this case, for the case of the VWC domain, there's a left-shifted but also bimodal-looking distribution, but many other such domains with similar distributions. So we take advantage of this to compare all domains by their distribution shape of all Revel scores, and we compare them using Jensen-Shannon distance, so just a measure of how similar two distributions are. And when we do this across all domains of all disease genes, we get a massive heat map that looks like this, but this allows us to cluster domains by their distribution shape into now 103 clusters. The median number of ClinVar variants now per cluster is 510, which is an ample number to actually calibrate these clusters. And there's a median number of domains per cluster of 53, so we're pulling in pathogenics and benigns from multiple genes per cluster. And all told, we can now calibrate 80 of these 103 clusters, representing now 91% of all variants. So we move from being able to calibrate 1% to now 91%. So how do we do when we actually calibrate these clusters? So to show some examples, I'm going to first set the genome-wide calibration here on the left as our reference. And now I'm going to show the calibration of one of our clusters. And so we applied the same local posterior sliding window approach that was applied to the genome-wide calibration, but now just to our smaller clusters with specific shapes. So here's one of our clusters. This actually contains all of those collagen domains that I showed in the previous slide. And what we see is with this cluster, we have a very right-shifted, actually both classes of the distribution. So the pathogenic variants are really pinned to the right side, and the benign variants are shifted even up to a Revel score of about 0.8. When we apply the sliding window calibration, we're actually able to achieve strong and very strong evidence on actually both sides of the distribution. Another way to look at this is to look at thresholds and how they influence all possible predictions. So again, this is the genome-wide calibration with those genome-wide thresholds. And this is a representation of all variants in this cluster. And I just want to point out a couple of things about this. First, we can look at just one sort of score threshold. So this is the pathogenic supporting threshold. And if we were to apply that to this cluster, what we would see is that many of these variants that are in the indeterminate range would be getting pathogenic evidence with the genome-wide calibration. The entirety of the supporting benign evidence range would get pathogenic evidence, and a portion of the moderate benign range would actually be getting pathogenic evidence. So this is like sort of an extreme case where the genome-wide calibration could potentially be giving inappropriate evidence of pathogenic where we should be giving benign evidence for some predictions. Another way to look at this is to look at the proportion of variants which receive no evidence. So in the genome-wide calibration, we have a lot of density of variants in the middle. About 32% are receiving no evidence. But in some of our high-performing clusters, that's reduced to, in this case, 5.3%. meaning nearly 95% of all predictions in this cluster are actually receiving evidence. So that's a way that we can directly reduce VUS because more of the variants are actually receiving evidence that we can actually accurately calibrate. And so, this is an example of a really good cluster where Revel is actually performing extremely well. But there are 55% of variants that fall into such clusters that have this increased performance by having fewer variants in this indeterminate range and increased evidence strength on either side. And so this is again, that college and domain cluster where we have this rightward shift. We have other clusters where we have a leftward shift, but still increased evidence on either side and a decreased indeterminate range. There are about an additional 22% of variants that fall into clusters that have a broadened indeterminate range and more variants than the genome-wide calibration receiving no evidence. But in these 22%, we're receiving more evidence towards one direction. And that's because some of these clusters are just so heavily skewed to one direction or another. So we have this right shift in cluster 38, and then a left shift in cluster, in cluster 90. And then finally, I just want to touch on the cases where we actually have reduced Revel performance. And so we have clusters that might look like this one, where we actually have this sort of centrally shifted distribution. And in these cases, this is actually what we think areas where Revel, the predictor, is just not making very confident predictions. And so one strength of this clustering approach is that we can actually identify where a predictor is not performing very well, but we can still accurately capture that in the clustering. And then in this case, we only apply supporting evidence and then up to moderate evidence at the very extreme ends, where most variants are still in this indeterminate range. But that just goes to show that when we apply this approach, we're not trying to improve a predictor's performance. We're just trying to more accurately represent what the predictions mean for a given gene. And so just to close up, the piece of this project that I think we're the most excited about is that when we apply this clustering calibration, we now increase the number of variants which receive evidence at the domain level from 1% to now 91%. And in doing so, we're also accurately representing what the predictions mean for a particular gene by the representation of the distribution shapes. And so some next steps are to apply this approach to other predictors. So we've done this also for alpha missense. MutPred2 is in the queue as well. And then apply this evidence to the VUS interpretation project. And then finally, we do plan to validate some of these clusters and evidence strengths with biobank data. And so with that, I just want to thank the Fowler and Sarita Labs, Doug and Leah for their support in this project. Everybody in BOLD has had a lot of input into this project, and thank our IGVF collaborators, in particular, Vikas and Peja, who have been instrumental in helping drive this project forward. So thank you all for your attention.